Hi, I'm Dr. Randall Thomas from Orthopedic Foot and Ankle Center. Today we're talking about bunionettes, or commonly known as Tailor's bunions. So Tailor bunion is the opposite of a bunion on the inside or medial part of the foot. It's on the outside or lateral part behind the baby toe. This is a bowing out of the bone or prominence that drifts over time more to the outside or lateral. Can lead to the toes, like the fourth and fifth toe, the fifth toe being the baby toe, tucking in underneath the other toes or drifting. It's a malalignment of the joint that can lead to inflammation and pain. We can not only see it go to the outside, but also down, and sometimes becomes a real prominence. These prominences can lead to a lot of callus and thickened tissue and pain when walking. Unfortunately, that can lead to walking abnormally and distributing weight different throughout the foot and having some other issues associated with that. Patients usually complain of pain at the outside of the foot, or what we call the lateral foot, where the baby toe meets the long bone. We see bowing out of the bone, and there's a lot of inflammation and prominence. You can have a bursa sac there and get bursitis. We can see a lot of callousing on either the outside of the foot or the bottom. Not only can it project out or lateral, it can also go down or plantar, so we can see a lot of callousing on the bottom of the foot as well. Even in shoes, these calluses can hurt. It can lead to blistering. And we can have a lot of difficulty fitting into shoes as the foot is essentially splaying or becoming wider over time. The cause is usually inherited or genetic. This has a lot to do with foot structure. Patients that have bunions and hammer toes not uncommonly will have deviation of the bone behind the baby toe. Can be traumatic, and that certainly has been seen in our practice, where you have an injury and the joint becomes more unstable. The long bone behind the baby toe drifts out and the baby toe starts to tuck in or underlap the fourth toe. And so a lot of times it's wear and tear, genetic, kind of degenerative breakdown, or more of an acute trauma that leads to it. Diagnosed typically by physical exam, fairly common findings of the bone deviating out, a prominence or a bump, and patients say it's the opposite of a bunion. It's rubbing on the outside of the shoe. Can limit the motion at the joint as well if we try to move the baby toe at that long bone because it's not aligned. We also can find that it can be found on x-ray in regards to the alignment being malaligned. The joint doesn't match up, so the cartilage doesn't sit in alignment. The bone is literally bowing out. Not uncommon to see spurs as that occurs too, and those can lead to a lot of the calluses and skin lesions associated with it. So typically it's physical exam and x-rays. Sometimes if we're concerned about bursitis along with the joint, we'll get ultrasounds or MRIs to evaluate it, but usually within one visit of physical exam and x-rays, this can be determined. The treatments vary. One of the concerns we see a lot with patients is trying to treat this conservatively because it's an issue of real estate in the shoe. The shoe is only so wide, and if we add padding, strapping, taping, it takes up more space in the shoe, makes the foot wider essentially. So first we start to do wider shoes, sometimes inserts. Again, those can take up space. Sometimes we'll pocket out that area where the insert essentially floats the bone and doesn't have anything there that would take up space within the shoe itself. There's other conservative treatments of topicals for anti-inflammatories, oral anti-inflammatories, splints that we wear at night to try to hold it in place. But a lot of times this is an issue of it can't be corrected without surgery and it's progressive. We initially tried these conservative measures, but at times as it continues to splay out and become more prominent, we have to go to next steps. From a surgical standpoint, this is treated typically with an open surgery, but there also are advances in minimal invasive surgery. This has come a long way, particularly over the past 5 years or so. Sometimes this can be done through a poke hole on top of the foot behind the baby toe, where we make a wedge cut in the bone and move it into position. Sometimes we put a screw in this or a pin. These are all internal, they do not stick out, and sometimes we don't even have to do that. We just put it in the right position and it stays in place. It all depends on how the cut is made, whether this is stable. Traditional procedures are open surgeries where there's an incision from the baby toe to the long bone behind this, accessing the joint, repairing the joint and any cartilage that we can, making bone cuts and realigning the bone so that the joint is straightened. When we realign the bone, we take the bone that's prominent on the outside and move it towards the inside. Sometimes this cut has to be made in an angle where we can move the bone over and elevate the bone so that there's no prominence when you walk, meaning it's not going to push on the outside or the bottom. When this is fixated, usually with screws, these are headless screws that don't stick out. they're not prominent, and it allows the joint to return to a good alignment. Many times we don't have to touch the baby toe, because when you bring the long bone over, the baby toe or fifth toe will realign. The recovery process depends on which surgery we employ. Some patients, this happens and they can't be off the foot for a long time. So if we do more of a minimal invasive procedure, then they can walk that day, particularly if we're doing it on patients that have neuropathy or can't feel and we're trying to offload a prominence and prevent a wound, such as in a diabetic with neuropathy, or in a patient with vascular complications where we can't have an open procedure. We don't always do these in those cases. A lot of times we do custom shoes or bracing or inserts, but when we absolutely have to try to prevent a wound, deeper infection, we will do a less invasive procedure, let them walk that day, and the bone will essentially go through what we call osteoclasis, or kind of finding the level it's supposed to be at. Traditional procedures where removing the bone, putting screws and aligning it, patients that can feel their feet, don't have neuropathy, they can also walk that day as well, usually modified with a boot or a post-operative type of shoe or sandal that we put padding and modify. Some folks are off the foot, depending on individualizing it to the patient, for several weeks, but usually after that they're walking in a boot. Typically not back into shoes until week 6, and so we're in a boot or a surgical shoe, partial weight bearing, full weight bearing. Eventually at week 6 we're walking in a shoe and doing an at-home rehab protocol or therapy. Some of the risks we can take down in surgery from an anesthesia standpoint, a lot of times these are done with a twilight anesthesia instead of a general anesthesia. We do it with nerve blocks or kind of numbing the area as well. The risk with any surgery is inherent for infection, typically less than 1%. Blood clot risk is very low because we're ambulatory and moving at an early stage. We certainly treat with anticoagulants as well. If there are any sensitivities to hardware or metal, we do have bioabsorbable implants we can use, so screws that look like a screw, function like a screw, but they're not metallic and metabolize or break down into bone over time. So there are options for those folks as well. Risk of recurrence can occur, but very low. Sometimes we'll see a little bit more prominence of the bone on the outside, but the bone doesn't deviate back. We don't see as much spurring. We could see the toe continue because of the tendon and muscle imbalance to contract, and that could require a procedure for the toe. If we think that's going to happen, we usually do it at the initial surgery, so we're not having to go back to surgery. In general, it's a fairly quick recovery and low risk procedure.